be reviewing a bone marrow biopsy sample. Now this belongs to a patient, a 16-year-old male patient, and he first seeks help of a physician because of a skin rash. And during examination, he's found to have hepatosplenomegaly. Physical examination does not reveal any lymphadenopathies, and complete blood cell count shows thrombocytopenia. The white blood cell and the hemoglobin level are normal. The patient undergoes a CT scan of the abdomen and thorax, where the hepatosplenomegaly is confirmed, and again, no lymph nodes of increased size are identified. And then they perform the biopsy sample, the bone marrow biopsy of the patient. Over here, we are looking at a fairly normal cellular bone marrow with regard to the patient's age. Even from low power magnification, we can actually make out an increased number of megakaryocytes. And when we move in closer, it's even easier to tell that the megakaryocytes here have increased in number, which gets us thinking. It suggests that the patient probably has a secondary thrombocytopenia. That means these megakaryocytes are reactively proliferating, and the thrombocytopenia might be due to the increased in size of the spleen where they are sequestered. Now, when we move in even closer, though it's not really easy to discern, but we can make out, let me move in even closer. Over here, as you can see, clusters of these atypical cells. They've got irregular nuclear contours, okay? They've got relatively open blastic chromatin. You can make out one or two nucleoli. And here, over here, you can see another cluster of, and maybe another cluster. But we can't really tell what they are, but they could be atypical lymphocytes. I'm moving. As you can see here, one tends to think that could these be intrasinusoidal in nature, because they seem to be following flowing in a file, let's say, following a path. And over here, you can even actually make out the sinusoidal lining, say over here, and it looks like it's branching on this side towards the right and the left. And again, you can make out that these are clusters, and they've got irregular nuclear contours. They're medium-sized, bigger than small resting lymphocytes, let's say. They've got open chromatin. You can make out the nucleoli. These atypical cells can be identified. Now, this is the reticulin stain. It shows that there is no increase at all in reticulin fibers. Now the Cd3 stain confirms our suspicion. And over here, as you can see, it points out an intrasinusoidal growth pattern. The sinuses are filled with T lymphocytes, which, let's move in closer, as you can see, are larger than these bystander normal small lymphocytes, much larger. And you can make out the intrasinusoidal growth pattern. These cells are also positive with TIA1, as you can see here, we have a paranuclear dot-like staining with TIA of this infiltrate. Again, you can make out that they're in clusters and files. They are negative with the CD5 stain. Over here, as you can see, these are the bystander normal T lymphocytes. These are the atypical population that we are referring to. They are also negative with the Cd8 stain, as you can see here. See, these are the normal T lymphocytes, and these are the atypical cells. Here I've moved in closer. As you can see, these are the normal lymphocytes, and these are our cells. They're negative with the Cd8 stain. They are also negative with CD4. As you can see, CD4 has highlighted the sinusoidal lining. It's also stained the T lymphocytes and probably monocytes and macrophages as well. But the intrasinusoidal population, as you can see, does not have considerable peripheral staining, as you can see over here. And they're also negative with granzyme B, as you can see here. These are our typical population. They're negative with granzyme B stain. Now I'm also going to show you the aspirate. Flow cytometry is also sent from this patient, and flow cytometry actually confirms the presence of an atypical T cell population, which composes around 1/3 of the T cells, and this population is double negative with the CD4 and the CD8 stain. And with those immunohistochemical findings, it is, and of course, knowing that the patient does not have any lymphadenopathies and that the patient has hepatosplenomegaly, it is fairly easy to diagnose this entity, this patient, as having hepatosplenic T cell lymphoma. And this is the aspirate. The aspirate was not really rich in cells, but amongst the cells present, you could identify these atypical T. Let me just. These atypical lymphoid cells with irregular nuclear contours. Some of them, as you can see, are actually quite blasting looking. Here they are, here again. They've got irregular nuclear contours, as you can see over here. And here you can appreciate the blastic chromatin and the irregular nuclear contours. Here's another one. So you can find these atypical lymphoid cells within the aspirate as well, within the cells in the aspirate. So this was a case, a typical case of hepatosplenic T cell lymphoma. It's early bone marrow infiltration pattern, and we diagnosed it with the patient's bone marrow biopsy.